We'll talk about unmet needs for blood testing and some case studies. Just some disclosures for me, investigator and work with some startups and the general sensor and testing space. Going to do a quick overview of testing in medicine. Blood pressure cuffs came out in 1881, X-rays 1885. You can see kind of a span from 1892 to 1914. A lot of early blood tests came to fore, as described by Osler in the textbook of medicine. EKG in the early 20th century. And of course, the glucometer, probably our most famous blood test that people can do at home. It's evolved quite a bit, starting with urine testing and blood testing, and now continuous glucometry. And of course, the pulse oximeter is actually one of the more recent tests that have been developed in common use. And we've got a whole host of an assortment of home tests now that people can do. If you're not a clinician, so I know that the audience is mixed, but a lot of people not directly involved in clinical care ask about what's the framework? How do I know where to focus my efforts on developing new tests? So you can think about certain criteria, such as high severity, impact, how many people are impacted, costs, and the location of care. So today I'm going to talk about briefly about how to think about this. So we can talk about the data. What data do we have overall? We've got good data on deaths, hospitalizations, readmissions, office visits, and I apologize. I know this will be fairly US-centric in terms of the data. So looking at the leading causes of death, obviously this is pre-pandemic. COVID would be 1, 2, or 3, depending on how you averaged out and the time of the year and the course of the pandemic in terms of leading causes of death. Of course, heart disease stands out, cancer stands out. Cancer in particular is interesting, of course, because it's really many diseases as opposed to necessarily one disease altogether. Lower respiratory diseases, I think, is an interesting area, under-recognized as a large cause of mortality and morbidity. And you can see here, of course, stroke, Alzheimer's disease, and diabetes round out some of the top causes of death in the US. So this could be one framework you use. Obviously in this framework, you would choose heart disease and cancer as areas to go after. So how else do you look at this? What's kind of an alternative framework? Well, you could look at severity in terms of the number affected, but also the cost. So I found this is a really fascinating chart. You can see the costs in the US, may not be reflective in your countries. But you see things like heart disease, actually, a decent number of stays in the hospital, around 700,000 stays in the hospital, according to this chart. But the median cost per stay is quite high, over $20,000 for the median cost of each stay. You look at something like osteoarthritis, affects far more people, and similarly high cost, not quite as high as a heart attack, the acute myocardial infarction. And you see heart failure, also a lot of people, slightly lower cost, but still substantial. And you look at something like diabetes, obviously affects a lot of people, but in terms of the framework of hospitalization, it's less of an issue in terms of number of stays, as well as the mean cost per stay. And of course, something clearly stands out here, septicemia. So when you have a massive infection, causes your blood pressure to drop, causes you to have this physiology of sepsis that we'll talk about later. So clearly this is, in the US, a big impact, high cost area affecting over 2 million stays in the hospital and a high cost of around $20,000 per stay. So we move from hospitalizations to readmissions. So readmissions are an issue because the idea is that readmissions may be preventable. You're admitted to the hospital, you have to come back to the hospital within 30 to 90 days. So, this is viewed as an area we can make a lot of progress. A lot of effort in the US is focused around this, and partially due to the costs, and partially, again, due to the idea that this is something that we can prevent. And again, you see septicemia really pops up as the #1 area of readmissions, followed by heart failure, and this is where diabetes becomes more prominent, as well as COPD and pneumonia. So it's, again, a different framework, and you can see there's certain recurrent themes of septicemia and heart failure here, as well as now diabetes. And these are readmissions for any cause. The index admissions, so the first time they're admitted, the large percentage of them, 20%, were admitted with septicemia, heart failure, diabetes, and COPD. So admitted at first for this problem, and then readmitted again for a similar problem, but could be any cause admission. You could be admitted for septicemia and then readmitted for renal failure, for example. So what's another dimension that we can look at this? What areas to look at? You can look at office visits, so ambulatory care. Here are the 20 leading reasons for office visits in the United States in 2018. A large number of visits overall, 860 million. Kind of a lot of kind of general visits here. Post-op visits are high, but of course you can see prenatal visits, of course very common. Knee symptoms, so knee pain, osteoarthritis, cough, upper respiratory infections, some sort of medication issue is also very prominent. And this is where now we start to see diseases such as hypertension. And you can see there are visits, a lot of visits for diabetes, but further down the list in terms of total number of visits. So in summary, these are the areas that seem to have popped out when you look at those multiple dimensions: septicemia, heart failure, heart attacks, diabetes, and COPD, looking at the primary drivers of costs or morbidity and mortality in the United States. So again, this is one framework. You may have different criteria, but there's not enough time and too many tests to develop. So it could be a guide as to what you want to pursue. And interesting, of course, a lot of these reasons for admission or hospitalization, these patients may also have cancer, but you can see it's interesting on these other reasons for admission, readmission, cancer is not clearly a driving cause of that. It may be, again, a setting. Cancer patients have high rates of infection and so forth, so it may be a little bit buried in these numbers. But thinking about it from the framework of septicemia as opposed to cancer may be helpful for you. To talk briefly about a research project that is ongoing here. I'm one of the investigators, along with my colleague, Professor Tom. So he's developed a sensor that can measure small molecules and large molecules in real time using aptamers. So the model is, if you have this sensor that can measure some drug or biomarker in real time, you could attach it to a patient in the hospital and even have a real-time readout like an EKG or pulse ox, and again monitor levels of drugs. In this case, we are looking at antimicrobials. We chose vancomycin as our sort of prototype case. As many of you may know, vancomycin is a drug that we commonly use in the hospital and requires monitoring because the therapeutic range is narrow compared to other antibiotics. Of course, you can also measure biomarkers, common biomarkers like lactate, cortisol, procalcitonin, CRP, some cytokine biomarkers. Of course, there are other drugs you can measure as well, anti-epileptics, immunosuppressants, substances of abuse. So this is a general sensor platform that uses aptamers attached to a electronic switch, a chemical switch that allows you to monitor levels reversibly in real time. You can see here a picture of so you can see here an aptamer. Aptamer changes conformation, and then the switch enables real-time continuous monitoring of the drugs with this electrical plane a switch is attached to the plane and then can be sensed. And you can see here's an example of doxorubicin. This is done in real time in a mouse from venous blood from a mouse with different levels of doxorubicin given, and you see a rapid response time. You can also use an optical sensor with similar, instead of electrically sensing the switch, you can use an optical sensor. So this is actually what we are pursuing now, using an optical sensor, and the research is ongoing. We are currently developing the assay for vancomycin as part of this sensor platform, and we will test this in the intensive care unit. These are some of our collaborators here on this project. Just a brief word about sepsis before Dr. Chang starts. As we talked about earlier, really large numbers, large mortality, big issue, lots of initiatives to prevent sepsis. Causes of sepsis: infections, lung pneumonia, upper respiratory infections, urinary tract infections, infections from the skin and from the gastrointestinal tract, and of course affects people predominantly older with weakened immune systems, chronic conditions. So lots of signs and symptoms you can follow. So these are clinical. Of course, there may be, and there are a lot of people working on biomarkers for this. And things that you could potentially test that are on the for predicting or for early detection of sepsis. With that, I'm going to hand it over to, whoops, wrong way, my colleague, Dr. Chang, to talk about case studies.
Okay, so I'm going to go ahead and share my screen. Okay, so I'm going to go over a few case studies in blood testing. No disclosures to make, and we'll start with our first case, which is procalcitonin in sepsis and infections. So our patient, he's 68, he's got diabetes and hypertension, and he's presenting with altered mental status and fevers, and he's admitted to the ICU after having found to have persistent tachycardia, which is elevated heart rate, and hypotension, low blood pressure, despite receiving IV fluids. He is started on broad spectrum antibiotics for sepsis, and the blood cultures are pending. And the procalcitonin is obtained and is elevated. So what is procalcitonin? So normally procalcitonin is the precursor to calcitonin, which is a hormone that's expressed in thyroid cells. So that's shown here on the left-hand side. Calcitonin actually helps regulate calcium levels in the bloodstream. During a bacterial infection, this can trigger the production of procalcitonin in other cells, so outside of the thyroid. So white blood cells, kidney cells, spleen, and fat cells are some examples. And this procalcitonin enters the bloodstream, and that can be measured and detected through a blood test. So we can use procalcitonin to help us identify bacterial infections specifically. And so in sepsis, for example, this is one schematic where across various ranges of procalcitonin level, we have different likelihood of sepsis or systemic bacterial infection. So less than 0.5 micrograms per liter, a little less likely, 0.5 to 2, it's possible, and then greater than 2, it's more likely and higher risk for severe sepsis. Similarly, for lower respiratory tract infections, we have a similar framework. So across different levels of procalcitonin, different likelihoods of a bacterial infection causing a pneumonia, for example. And we have used procalcitonin during the COVID-19 pandemic as well. So as we know, COVID-19 is a viral infection, but oftentimes when patients come in quite sick, we start antibiotics just to make sure we're covering a potential bacterial co-infection. And so procalcitonin can be helpful in this case to help identify patients who truly have a bacterial co-infection or may be at risk for bacterial co-infection. So how is procalcitonin used in sepsis? Well, this is one example of procalcitonin in terms of initiating the beginning of sepsis or diagnosing sepsis. So here we have with lower procalcitonin levels, less than 0.3 or 0.3 to 0.5, the likelihood of bacterial sepsis is less likely, and so you may want to defer antibiotics. But above 0.5 or above 1, the likelihood of bacterial infection is a little bit more likely, so antibiotics are encouraged. Of course, the caveat to all of this is that if you're a clinical suspicion for a bacterial infection, sepsis, you should always start antibiotics. You shouldn't wait for this blood test to come back. Oftentimes, we will repeat procalcitone 40 hours later and then trend it on a daily basis. And this is helpful in the sense that it helps us decide whether to de-escalate antibiotics. So oftentimes in sepsis or bacterial infections, we don't necessarily know the source of an infection, and we can use procalcitonin to help guide us on de-escalation. So for example, if your procalcitonin drops by 80% or more, or drops to a low level with antibiotics, then you can consider de-escalating or peeling back your broad spectrum antibiotics. If it's still high or it's increasing, then certainly you may not want to de-escalate antibiotics. So what are some pitfalls and limitations? Well, like all blood testing or any testing, there are limitations in sensitivity and specificity. Procalcitonin, unfortunately, is positive not just in bacterial infections, but situations of massive stress like major trauma, treatment with cytokine stimulating agents, cardiogenic shock, graft versus host disease. Certain cancers can cause it, end-stage kidney disease, and fungal infections. So you do have to take the right clinical context. The literature supporting the use of procalcitonin in infection is also really only strong for certain situations. So the most data is for sepsis in antibiotic de-escalation, so trending procalcitonin over time. And if you see that it's dropping, the de-escalating antibiotics. And it's also fairly strong for use in lower respiratory tract infections. Another limitation is that procalcitonin, at least in the United States, is not readily available in all institutions. So our institution is a big proponent of it, but in other institutions, they may not use it at all. The results also are not available fast enough. It does take several hours for the results to come back. And when you have a sick patient, you may not want to wait for procalcitonin to guide treatment. And so ultimately, you can't replace clinical judgment, but this is a very useful adjunct to help you. So our second case, I'll move on to heart failure, so BNP and NT-proBNP. So 61-year-old hypertension, diabetes, common shortness of breath and leg swelling, and we obtain an NT-proBNP. So what is BNP or NT-proBNP? These are peptides. In heart failure, the walls and the chambers of the heart are being stretched. There's increased pressure, there's dilation, and that produces proBNP, which is then converted to NT-proBNP and BNP. From a laboratory standpoint, the difference between the two is that NT-proBNP has a longer half-life, so it hangs around in the blood a little longer and it's more readily detectable. So it helps in terms of increasing sensitivity of the test. And really the use of BNP or NT-proBNP starts from the Breathe Not Properly or BNP trial. This was in 2002. And basically they established that we can use BNP to establish or exclude a diagnosis of heart failure, patients presenting with shortness of breath. So here you can see that for patients who are presenting with shortness of breath without heart failure, their BNP levels are lower. Patients with shortness of breath due to heart failure, their BNPs are higher. And then patients who just have a history of heart failure, but they're presenting with shortness of breath from other reasons, their BNP are somewhere in the middle. And then similarly, across severity of their heart failure, so patients with a very severe heart failure symptoms, so New York Heart Association class 4 symptoms, their BNPs are higher. And then if they have milder symptoms, their BNPs are lower. So what are some potential uses? Well, we talked about diagnosis of heart failure. We can also use BNP to follow patients throughout hospitalization. Less of that. Some physicians use BNP to follow discharge to prevent readmissions. They can use it to monitor outpatient therapy, to guide outpatient therapy for risk profiling. So oftentimes we use it as for preoperative evaluations, and then patients with valvular heart disease. Limitations, once again, sensitivity and specificity. So just from a cardiac standpoint, heart failure is not the only thing that can cause an elevated BNP or NT-proBNP. ACS, which is acute coronary syndrome, heart attacks can cause it, valvular disease can cause it, For non-cardiac causes, older patients tend to have elevated BNP, patients with renal failure, severe pneumonia, sepsis, cancer. Obesity actually decreases BNP as well. So ultimately, you do have to take everything into clinical context, but it is a very useful tool, and most patients presenting with shortness of breath will end up getting a BNP actually in the emergency room. The last case is on diabetes, so continuous glucose monitors. A 67-year-old female has uncontrolled type 2 diabetes in clinic, and her A1C is 10.9, so this is uncontrolled diabetes. Typically, our goal A1C, which is a marker of diabetes, is less than 7, and we prescribe her a continuous glucose monitor. So these 3 continuous glucose monitors are the most common ones we use in the primary care setting. There's the Freestyle Libre, the Libre 2, and the Dexcom G6. The 2 Freestyle are 14-day sensors. They attach onto the skin for 14 days, and they have to be replaced every 14 days. The G6 is a 10-day sensor. This is an example of how the printout, the readout looks like. You can see you get the nice glucose throughout the day. You can get a percentage within your target range, percentage that are higher than your target range glucose, and lower than your target range glucose. And this is really an advantage because traditional testing for blood glucose is through finger sticks. You need lancets, you need test strips, you need a glucometer. You have to poke yourself multiple times throughout the day. And so in patients with diabetes who are on multiple insulin injections, who need to track their sugars closely, a continuous glucose monitor can be very helpful. Pregnant women who require tight glycemic control is another example where this can be useful. And patients with hypoglycemia who may be unaware that they're hypoglycemic or high risk for hypoglycemia, this can also be very helpful. And then just patients who have trouble using their finger stick, whether it's because they're busy at work or they have dexterity problems or vision problems, using a CGM or continuous glucose monitor can be helpful. And lastly, patients whose A1C, which is our long-term glycemic control, is inconsistent with their glucose levels, that can be helpful as well. So what are some advantages? Well, one, it's user-friendly. You get less finger sticks. You attach it on and just read it with the reader. But it actually also motivates and educates patients. When they see their glucose trend throughout the day or in response to a meal, they're very motivated to change their lifestyle. They see the sugar go up, and they may change what they eat going forward. And there is data to support improvement in A1C, so better diabetes control, and also a reduction in hypoglycemia risk. What are some challenges? At least in the United States, there's difficulty with insurance coverage. You have to meet very specific criteria, at least through Medicare, in order to have it covered and paid for. You do have to replace it periodically. And there is also an accuracy issue. It's interstitial fluid that it's monitoring, is not your actual blood. But this accuracy is improving. So the error rates are less than 10% from 20% in the past. So those are the 3 cases of various blood tests that we use in the clinical setting. And once again, thank you everyone for giving us the chance to present.